Stuff coming up. Okay, a couple of things. Housekeeping, which is my way. You got a couple of messages. The first message, I just wanted to let you know, I have to, whenever you make a change in the syllabus, I had to make that effectively documented. So basically, to just make sure everybody understands what you. I never believe in dropping an exam. It's okay. The unusual as I thought about it, talked about it, thank my wife talking about it, that it's just such an extraordinary circumstance this year that, since so many people are going into health related fields and nursing fields, when you make an error or they follow you around. I mean, it's hard. That's the whole idea of no extra credit and things like that, which again is going to make me sound like I'm talking out of both sides of my mouth to your advantage very shortly. But that's number one. Number two on the hit parade is this thing, this assessment link. Every university, every college you're constantly being evaluated for accreditation. And then there's like the nursing program, it's got its own other accrediting, all of these things that are part of it. So part of accreditation means we have to do these assessment things for the students. It basically gives us a snapshot at where the students are. It's not negative or positive. It's just stuff that we have to do, particularly for what they call core courses. This is a core course. What Dr. Robbins does with the lab, if he's going to employ it or not, I don't know. Or maybe you know that I don't know. So this is something we would like you. You can't force somebody to fill it out. We very much like people to fill it out. So ergo, we have been authorized, honestly, in the email that we got this, said we can offer an incentive. So even though I don't believe in extra credit, incentives to fill this out because it makes me look good. It make you look good. So one time offer only. Use your credit card to do this. Like I'm on TV, so I'm shopping. Okay. If on the next exam, for instance, you can get, by filling this out, I know we'll fill it out, but if you happen to get like a C plus, you will get a one-time only grade boost, the next level. So C would go to C plus, C plus would go, got it? So there's the incentive. That's the closest thing you'll ever get from me for you guys can't. What's your talk? And you have a Duke shirt on? Oh, give me a break. Oh, God. Sorry. Yeah, basketball. Well, the Duke. Robert Morris, every time they'd qualify for the tournament, typically they would get stuck against Duke. Not last year in basketball. Cannon fodder. One year they won their entry level, their playing game. The reward, Duke, who eventually won the championship. So I digress. Okay, moving on. So everybody got that? Satisfactory? Nobody's going to complain to the management? Go ahead. No, I know, I'm joking. So, okay, so on that note, it's Friday. This is one of my favorite lectures to give. Okay, I have a little extra stuff to look at with regard to radiology. A UK site I found this morning, was great. Okay, just out of luck. So I'm recording here. This is what we're working on. So this is the same, and we're not going to do the bone disorders, just not enough time. So let me just buzz back to where the fractures are, and everything will be good. Here we are. And so what I effectively understand, what a fracture is any interruption in the integrity of the bone. They can call it 1,000 names: cracks, chips, mini breaks, I can't see the break, non-displaced. They're fractures. Period. End of sentence. And healing will ensue. Whether or not it hurts you, whether or not what the source of it is entirely different. So understand that's the true definition of a fracture. I hate it when people play games like that. And doctors have a tendency to do that because they're trying to minimize things or what they are. I mean, I think I always think you have to be upfront with the people you're treating. If you're going into a treatment-related field, I mean, unless you're instructed otherwise by someone above, by some policy, I like to tell them don't worry, this is going to be all right, because you never know. The days when don't worry, we'll take care of you. People need to know what their options are, etc. It's all about being informed. So, and I agree with this. When you're young, most of the time it's traumatic in orientation. When you're older, most of the time it's from what we call a pathological fracture, means the bone has somehow been weakened, and by far and away, the topic for Monday is the cause of this called osteoporosis. Bone has weakened. I mean, that it's nothing, and it does include things like tumors. It comes things like bone cancers, other kinds of bone diseases. There's lots of things that can induce that as well. This is the classification. And the single most important of these is this one, open, which is also known as compound, closed. Guess that's it. So, and I'm not going to, and believe me, what I'm not going to do is reproduce fracture image, get x-ray or and say what kind of stuff. I'm not going to do. So effectively, what does it mean? When we're talking about the first thing, we're talking about is it complete or incomplete? Complete means it goes all the way through. That's a complete fracture. Incomplete could be something like this. It could be horizontal, could be vertical. It doesn't go all the way through. We'll talk about the distinction of incomplete fractures in adults, children, subsequently. For the time being, let's just think of that as being adult bone. So, and that's the way we describe it. Is we say it's through and through, and that basically means complete or incomplete. That tells you something. And believe me, depending on, and you'll see down the road, actually in general, I'd rather have the fracture line going at an angle than going all the way across. It's just a little bit easier. It's about surface area and from an ability to heal. The other thing they talk about is displacement. They don't even mention the word angulation, which I have no idea why. But that just tells you. Displacement is, I agree. In that sense, ends retain their normal position. So something like this would be a non-displaced fracture. A lot of times you can't even see a fracture. These are varying degrees of displacement. So it can be farther apart. It can be moved apart, even though it's not necessarily that far apart. And now when you get to something that's maybe not that far apart or is far apart, it's often an angle, we call that angle. I'm telling you this more for context. Because if you're reading a report of an x-ray, you have a patient, you're looking through their chart, and these days probably electronically looking through, however one looks at it today, not even walked in a hospital floor, other than to visit a sick friend for 25 years. It gives you information. It paints a picture in words. That's how my radiology professor, when you get a report of an MRI, a CT, or all those things, it's going to tell you something. And that's why I'm sharing this with you and acquainting you with this so you understand what the language means. So yes, it's a fracture of the distal tibia that's non-displaced but 15 degrees angulated medially. And other than that, there's no remarkable findings in the bone. The joint is intact. That's the way it would be described. It should be in your mind, painting a picture with words. And so that's the kind of thing. And then if there's problems with the bone, they describe that, or whatever the other circumstances are. So that covers all of those. But the biggest deal of all is open versus closed. The better definition of understand, penetrating the skin is not always the way that fractures are open. Open means the bone is exposed to the air. You could take a fall on a concrete step. I did that, by the way, this summer, walking the dog, and chunked off a piece of skin. If bone had been exposed, that would have been an open fracture. You could stub your toe really bad, and the nail starts to come off. And if you looked under, you learned about the nail bed. The nail bed is adherent to the bone. If the nail bed is lacerated, if it's torn, bone's exposed to the air. That's an open fracture. Or you could have bone that's sticking out. That's an open fracture. And a lot of times what we'll see, particularly in sport injuries, when someone will run, catch their ankle, you hear it snap, the bone will actually penetrate, and then they'll immediately respond by guarding or flipping and trying to put it back in place. It's like, oh my God, and the bone goes back in. Now you have an opening, And you have to probe that opening to see if it's just a little cut in the skin or if it goes all the way down to the bone. When all the way down to the bone, why is that important? Bone that has been exposed to the air in any way, shape, or form is presumed to be infected, period. And if it's infected, it requires antibiotics. And if it's infected, here's something else that we talk about a whole lot in micro. It requires to make sure that they're up to date in tetanus prophylaxis. Because by definition, that is a tetanus-prone wound. There's a whole way of classifying wounds. When I do micro, I do that. And tetanus-prone is a big deal. So all of that becomes part of it. And because it's already been presumed to be infected, it limits your ability to operate on it. Because something that is already infected, you are very limited in how extensive you can do, because once it's infected, if you open it up further, it's more likely to spread the infection. So these are all things. These are what we were taught. Now, maybe I'm talking, as my dad used to say, out through my chapeau, meaning out your hat. But nowadays, we have another area you're speaking out of. Don't start. I know what you were thinking. I was going to say talking out of my ass. Look, never mind. Like I said, I haven't operated and seen a fracture patient in 25 years, so maybe the rules have changed, but I don't think dramatically so. Because understand, these are certain things that are just, that to me are just entirely too constant. Maybe their approach to treating him is different, but being very cautious about spreading the infection would never change. So when you see that, you see the words compound or open, that's significant. Closed, it doesn't imply the severity of the fracture. I mean, I've seen closed fractures where it was turned sideways, where all of a sudden the foot's pointing, rather than pointing north, it's pointing due east. Yet the skin was closed. What that allows you to do, basically, is, I mean, you can go in there and fix it right now, or as soon as the swelling goes down, reasonably speaking, and put it back where it's supposed to be, because you're not worried about infection. And then you go up to an operating room and do it under the appropriate, et cetera, et cetera. You get the idea. That's why that is important. And I can't emphasize that enough. All of those things. So the words themselves don't necessarily imply severity, but they really they imply how you have to treat it and maybe limiting significantly the treatment options at first. I told the other class the same anecdote that I told you. I mean, I was lucky enough to do my 2 years more or less as a general orthopedic resident. Not entirely, but I had a lot of exposure. And the first time I was covering emergency room as a junior resident, I wasn't attending it. There was an attending there, meaning I'm just working there. And the first night I was working there, I mean, out of nowhere, we got not one, and this is the whole idea of emergency rooms. We watched that show, The Pit. It's exactly what happens. You go from nothing to chaos in an instant. We were like that. All of a sudden, bang, out of nowhere, they bring in some poor older man who had fallen off a roof with tar on his femur sticking out here above his knee. And I'm going crazy, and I'm sweating bullets, because the last thing I want to do is call my boss, get called in on a Saturday night when he's probably out with his friends or his wife and his kids. And the attending comes to me and goes, "Oh, Lou, I called Dr. His name is Dr. Nappy. He died a few years ago. He's coming in." I'm like, "Oh!" And thankfully, the first words he came when he looked at the x-rays, I didn't even see him walk in. I'm pulling my hair out, such as, well, I had to hear that. Okay, not that funny. She's laughing at me today. Okay. Pull my hair. He goes, "Oh, you're Lou. Oh, you were right. I had to come in." I didn't even call him, but I got credit. As that was happening, there was another, while I was pulling my hair, there's another guy screaming. The guy worked at a pizza shop. This is an older man who had the knee sticking out, had the bone sticking out. Pizza, "Oh my God, they shot me. We didn't see any evidence." They brought him in screaming, fully closed. There was some blood. And finally, no, we were so crazy for the first guy that as I've seen this other guy, I'm starting to lift his leg and I see blood underneath there. I said, "Oh my God, we had to cut off his," which you do all the time. And underneath there, you could see the bullet hole. And clearly it was going to be down to bone. It was right into the bone. I had two open femur fractures from different sources. One where the bone had been, where a bullet had opened it up to expose to the air, and the other where the fall had, in a matter of 20 minutes. Absolute chaos. That was a very long shift. I think that was probably the better part of me being on duty for about 16 hours nonstop. But when you're young, you can do those things. So it's very, very interesting to understand. We ended up with those, both those men ended up in intensive care because of the severity of the injuries. They didn't have operations at that point. We put them in traction, meaning we basically had to immobilize them. We had to put a pin through their leg to hold them, and basically traction holds them in bed, and just pull the bone pieces apart so we could start the wound healing process, and antibiotics and tetanus and blah, 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 blah. So, and because that one guy had fallen and one guy had hit his head, I'm at 3 o'clock in the morning. I'm calling doctors, getting orders from specialists. It's a crazy world. Crazy world. So all of that's part of what I'm trying to tell you. And so this is the whole idea. All of these things to understand it, and it's not just I was fortunate. Any doctor who worked as a resident in an emergency room, even an inner city or just a busy emergency room, didn't have to be in a trauma center. They all have war stories. We all have war stories. Great war stories. Just do, because that's really how you learn. You're just so overwhelmed by all of that stuff. Okay. So that's it. This is how we really classify them. So when it comes to this one, the lecture part of that, we have typically, if you have, let's say, take a fracture, this is an oblique fracture, that means. If you have it like this, you have two pieces, piece one, piece two. Some people might have wrong, I hate to use the term simple fracture, but fair enough. Simple implying one fracture line. When you have a second fracture line, you are always going to have at least three pieces. When you have two fracture lines or three or more pieces, by definition, we use the term comminuted. Bone fragments of three pieces. You can see this is probably more than three pieces. And yes, they're making a comment here about elderly bones being more brittle. This is not an elderly bone. It's got really good allotropic life. It's got really good, you can see the difference between the view next to it, which has osteoporotic bones. So if you take a good look at it, see the difference. This is, you can see, we call it moth-eaten, ground glass appearance. You can see right through it, versus you can see this is all the calcium salts. This is the relative absence of a lot of the calcium salts. And so that, my guess for that individual, for as long as I've been doing this sequence, it strikes me that's like somebody had been struck by a car bumper, because it's right about the area where you would expect a car bumper to be. And sometimes you'll see those. I mean, with a lot of accidents, we had a guy who was hit by the side of a car, or whatever the manner was that he was hit. He had a full bladder and it burst his bladder. Fun stuff. Not for the person. I'm not making light of the person. Young doctors in training, they thrive on this stuff. You're energized by it. So here, to me, these are multiple fragments. This would be very challenging. You'd probably have to try to put it all together. So now if it was open to the air, now you would have a comminuted compound fracture. But the word comminuted doesn't imply severity other than multiple pieces. It might be a fairly straightforward fix. This is the classic compression fracture. Basically, and the majority of them are in the spine. This is how hips fracture. Typically, they are due to osteoporosis or some problem that's going on with the bone. It could be a cancer in the bone. It could be a benign tumor in the bone. Understand, when we use the word tumor, it does not equate to cancer. 90% of tumors are benign. And there are benign bone tumors, plenty of them, but they still weaken the bone. So a pathological fracture, which is what these are described as, means there's some pathology, some disease process, infection, metabolic bone disease, nutritional defect, whatever. Okay. Some type of hereditary defect. There's something that occasions that. By far and away, the most common of all of these certainly is osteoporosis. And what happens is this squishes, like a better term, and what it would typically does depending on what, like say something like this. Now that's the intervertebral foramina. You might remember that from anatomy. That's where the spinal nerves exit and they get pinched. And then you, whether it's acute sciatic pain, and when we see it up in the neck area, the thoracic area and cervical area, then you begin to see things in elderly people how basically the serial compression fractions, they'll shorten and this type of thing. So the reason I was in the emergency room, my first wife was first assistant head nurse and then the head nurse of that emergency room. She became a head nurse when we got married or shortly around that time. And so I got to spend a lot of time. I'm going to just hang out there and get to do stuff. And so she, very diminutive, 5 feet and maybe a half inch tall when we got married. And we met 26, 27 years old. She's probably now, she'll be 75 January. She's a couple inches shorter from osteoporosis. And I'll give you a little bit more information about it. She had all of these risk factors for osteoporosis. And despite doing everything possible, it doesn't mitigate. I mean, it mitigates it maybe a little bit, but that's what happens. So there is porous bones, and it doesn't have to be extreme trauma. There's a lot of things we call repetitive microtrauma. That's what I was saying before. The classic example of the hip. We looked at the hip and how the bone on Wednesday. This is what happened. The bone gives way, and then the person falls. Not the other way around. Most of the time. So that's an ongoing misconception. This is the spiral fracture. This is, you can see, is adult bone. Here's children's bone. You can see a growth plate. This is a fracture for the growth plate, and a fibrococcygeal flate fracture. This is a spiral fracture. Most of the time in sport, something causes the foot ankle assembly to be planted. We see a lot of these in skiing when the boot doesn't separate from the ski, like a skiing accident, and then the body twists depending on what the nature of the pileup is. And there's all sorts of classifications about injuries from our European friends. I've been particularly with skiing, particularly downhill and some cross-country skiing injury. And the reason doctors classify things is because it tells you how to treat them. So we look at different ones. We were able to look at it. Oh, this is a such and such, a class 1 or a class 3. And the same thing with cancers. Is it class 3B? Is it class 4A? And it tells you basically the guidelines how to treat. Same with infections. We're always classifying and categorizing things because there's a right way to do it. It's a name you're going to all be very familiar with if you're in healthcare, called standard of care. Standard of care has to be observed unless you have an awfully good reason. Okay. The drug of choice for this particular thing is amoxicillin. Why didn't you use that? The patient's allergic to amoxicillin. Okay, good answer. Moving on. You see, that's what I mean. The standard of care has to be observed. And if you have to deviate from it, which is fine, you just have to have a reason that justifies your deviation from it. In whatever you're doing, if you're treating somebody, why did you start the IV over here? Because the site was compromised. There was an open wound at that site. There was a risk of infection. Good answer, move on. Exactly how it works. Because that's a lot of stuff many of you in this room are going to be doing. Okay. You can't just, I always started here, I'm going to start here. Doesn't work this way. This is interesting. So typically that's a spiral. We see spiral fractures in children. What might that suggest to you? The other group had 2 answers, both right. See a little kid, 8-year-old with spiral fracture near humerus up here. How would they get that? I don't figure they're out skiing. No, they could be. Okay. Surprise, your silence is astonishing. Would the hint be children can't protect themselves? So we have to be constantly observant of abuse. Good answer. Best answer. The other answer is trauma. Well, it could be trauma. I'm not negating that. Oh, gosh, we were friends with a 9-year-old girl who was a downhill skier. I mean, and you know, in competition. So, I mean, you can understand that. Everybody. I'll say it to you many, many times if I haven't done so already. Licenses are very hard to get and very easy to lose. If you have a suspicion, depending on what your role is, if you're in healthcare and you have a suspicion that something is happening to that child, neglect or abuse, you're not making a value judgment. You have a legal obligation to say, if you see a spiral fracture in a child, you have to report that to your supervisor. If you're the supervisor, you maybe have to report that to the attending physician. If you're a nurse practitioner, okay, and you're calling the shots by yourself under the overall guidance of another physician who's not necessarily on site, let's say at an urgent care place or something like that, you might have to turn around and you have to notify social services. It's not discretionary. Okay. Because what happens is if that's the kind of thing that is potentially so suspicious, you must address it. Okay, it's not up to you. If you're in an emergency room, it's absolutely going to happen. They're first thing to get social services in, and there'll be a whole. You can see some big scenes about this because they may say we have to keep the child here until we investigate. Understand that the child can't protect themselves. What happens is, and why it could affect you potentially legally and maybe impact your ability to continue in your profession is if it happened once, it's going to happen again. And 3 weeks later, they're in another emergency room with maybe a worse injury. And all of a sudden they go, what about this one? And somebody really gets their eyes up. Oh, yeah, we went to so-and-so. And they're going to find out, believe me, because then they're going to start to investigate. And they're going to find out that they came to your place and your name or somebody you know's name is on the chart. And now you are complicit. Heaven forbid something really terrible happened to a child. That's your it's a responsibility. You understand, sometimes oh, I know the family, and it doesn't count. You're not making a value judgment. I've been sharing this anecdote and I'll share it again. I adore my daughter. My daughter had a baby when she was 15. So she's a wild child. When she's 14, she's mouthing off. She's calling her mom every name in the book. It was bipolar, medication, the whole thing. And one day she said something just got me. Where am I with? It's me. She had a little droplet. You could see there was a little droplet of blood or a little wound that was here. She went to school. They reported it. I'm fine with it. I wasn't angry about it. They're doing their job because they are protecting her. I'm just a true story. Social worker came to see us at our house. She could had to have her there as well to observe the whole environment. She started mouthing off worse. The social worker. By the time she goes, oh, I've told your mom and dad. She looks at us and goes, I'm amazed. That was all you did. We weren't in any trouble. She goes, oh my God, I can't believe how hard she is to deal with. I mean, I can't even tell you how many times she's called me and go, I can't believe what I was like for you. I mean, she's wonderful. Yeah. What are you going to do? Don't tell her I said that. Still an element of wildness that's there. Just don't. So moving on. I have great stories for my children, as you're probably already hearing. That's not necessarily a great one, but it points out what I'm trying to say. I'm never mad at somebody for doing their job, because that's their job. Okay, and particularly when they're protecting they're in an effort to protect someone who, quote unquote, can't protect themselves. It's really important. If you're behaving appropriately, it's not going to impact you. This is an epiphyseal plate fracture. This one is displaced. It's not angulated, it is just displaced. So you can see the shaft of the femur. I mean, and this is right through the growth plate. If it's much more problematic if it goes through here, if it happens to go through the epiphysis and into the joint. Then that becomes a real problem because that can affect the way the bone will grow going forward. And a lot of times in that situation, you have to, the potential for one side not growing the same as the other side exists. That's a more complex. If that happens, I would always refer that patient, and I can't remember ever having one, I would have referred that to a pediatric orthopedist. But sometimes they have to stop one plate from growing to avoid having a really distorted lip and a distorted joint. But so these are pretty easy to put back into place and hold. Most of the time you don't. Children, 3 weeks immobilized, wonderful, works great. So I mean that's just another one of those. You see, this is the skull fracture. This is a so-called, as you can see, depressed skull fracture. It's not going to, schematically, you're not going to have someone who looks like a golf ball hit you in the head or worse. But you can see what happened. Remember that sort of sandwich in the skull, cortical bone. The moment of force pushed the outer bone in to the cancellous bone, and the force continued, and it led to the fracture here internally. The big problem with that is obviously potentially what it did to the brain. I mean, the bones are pretty good at absorbing a lot of the force. You really have to be watchful. Even if it's not a fracture, when there's head trauma in adults and in children, it's very difficult because you really don't know the full extent immediately. And most of the time, and the thing you have to be, because they hurt, you really can't use strong pain medicine. Basically, all you can use Tylenol, that type of thing. Narcotic analgesics are contraindicated, meaning you can't use them because they cause respiratory depression. And if this affects an area that involves respiration, somebody could be in fatally big trouble from that. The other thing that you have to do with people like that, and you'll learn about these, maybe you're already aware of it, are called neurochecks. And particularly little kids hate it because every 15, 20 minutes, when they're trying to sleep, you got to go and wake them up. You quit waking me up, it makes you cry and back to sleep. Because if you have to assess them for sluggishness, are their eyes responding in the appropriate way, and it's because that will be signs that there could be a bleed inside, and that requires immediate treatment. The giveaway that could be happening in an adult or a child, projectile vomiting. If you haven't been told this, or if they don't tell you this, either in nursing or health sciences, remember it. Remember it for your family. If somebody has head trauma like that, maybe there's a concussion, maybe they're not. And that's not the kind of thing, this is not a value judgment about urgent care. That's the kind of thing you take to the hospital. They're going to probably have to drill a hole and get fluid off the brain. That's a subdural or subarachnoid hematoma, most likely. Please. So these are all things, like I said, if nothing else, my comparative wealth of clinical experience should be adventitious. And then all my wealth of parental experience should be adventitious. But the only one of my kids you're likely to meet, because he probably is working around here, is my middle one. Nevertheless, so here's what I mean by depressed. And this is the distinction. This is growing bone. You can see the growth plate. This is an incomplete fracture. We call them green stick. An incomplete fracture in children, the analogy is like you're getting firewood or a campfire. Okay, if you snap the branch and it's brown and snaps easily, good, dead firewood. If it's green inside, it'll bend, not snap. That's what bones do. And a lot of times, interestingly enough, you have to take the child under anesthesia because it can bend. The bone can be remarkably bent. And then you almost have to complete the fracture. And again, they heal very well. So it's almost like you break it so you can get rid of the bend and put it in a cast or immobilize it in some way, shape, or form. So that's the distinction between an incomplete and a green stick fracture. One is in mature bone, one is still in growing bone. And that's where they come up with the analogy, flexible, blah, blah, blah. One side of the shaft, the other side bends, and the severity of the bend is like that. And then the whole idea, when we use the term reduction, we're reducing the deformity. So closed reduction means that you do not have to make a cut and put something in there, or you don't have to make a cut to remove fragments so you can straighten out the bone. Any way, shape, or form, or put internal hardware in there. They don't always imply it. So when you see something, and this is something from a hospital sense, you see, oh, we're doing a closed reduction with percutaneous pinning. Meaning, okay, it's distorted. We're going to put the child or the adult under anesthesia. We're going to reduce it, manipulate it back into place. And since it might be unstable through the skin, that's a little bit different than open, we'll introduce, and then again, I'm not going to ask you about this. You'll introduce pins in there to hold it in place. And maybe put the cast on. And you'll see, so I have some slides. That's the way we'll use what's called an external fixator, which are very popular today, though they've been around for 100 years. In medicine, like in life, things go in vogue and out of vogue. It's like fashion trends. Okay. You just see sometimes short skirts, long skirts, whatever. All those types of things have changed over years. Men's clothes, different things like that, sizes of lapels. Which became from an age where we wore bell bottoms. That was hippie time. Don't look at me like that. Don't judge me. I started in college the summer after this thing called Woodstock you might have heard of. I didn't hear that. Oh, I'm a stranger in a strange land. Didn't hear that. You heard of it. Look it up. It was a peaceful rock festival with New York State. Unlike Altamont, which is a fatal rock festival out in California. Motor raceway with stones. Rolling stones. Okay. So, we'll educate you. Ask your grandparents about the music they listen to. How old are they? Is it a 6 or a 7? Okay, don't know. Help me. What do you think I'm listening to on this? Not techno music. Which my daughter was dancing to at her wedding. My daughter's 40 going on 20. I mean it. So nevertheless, stop talking about her. When you talk about an open reduction, that's the typical surgery that you see. You cut it open and you fix it, and then we immobilize it. This is how they heal. We're almost done. The hematoma is basically what happens is this. The torn blood vessels, not only do they start to have blood come into the area, but when there's tissue damage, immediately it starts the healing process. It summons white blood cells, it activates platelets, all of those things to start to make this big blob of blood called the hematoma. It's typically held there by that periosteum. And because it's being stretched and there's pain fibers, that's what really hurts. It's about the first 3 days that this forms. This is the first and very inflammatory phase. And it depends on the severity of fracture. I mean, if something that's going to have to be operated on, that's a whole different story. I mean, then you might have to do this. You might have to take care of that sooner than later. But let's say this is a routine fracture that you're just going to put into a cast. So it looks like this. The elevation of the periosteum is what does it. Again, they're all the same tissue. Fibrous, cartilage, and bone all come from that same connective tissue origin. So once you start to clear the debris, that's why it takes a few days sometimes to see the extent of a fracture. Collagen, holding it, bracing it, and then a combination of first fibrous, then cartilaginous tissue, and later bone begins to fill the gap and rebuild it. Again, we don't repair it, we replace it. We gobble up the damaged stuff and we start making anew. We're building a new scaffolding, and then we're going to put new glass in, new steel, new drywall, whatever. And so it starts to repair itself. The first stage where we begin to get it knitting together over the next, roughly by 3 weeks, is called a fibrocartilaginous callus. Callus just means a hard area. And so this is what that kind of would look like. They always use this color for cartilage. And it's getting vascularized, and that's going to get rid of the cartilage. And then typically we start to see bone early, but probably somewhere, I would say from the time of the fracture, 4, 6, 8 weeks, depending on the bone, how badly it's involved. It's not a hard number. We begin to see what's called a bony callus. Now you begin to see on x-ray how it begins to look. And that's why that 2-month x-ray is important, because it'll really tell you if it's filled in, if it's going to take more time, does it still have to be in a cast? And a lot of times it's determined if take it out of a cast or out of a splint or out of a brace, it's how much it hurts. If it's solid and not moving around, that's okay. You know, you don't have to have the x-ray evidence. But this is where you see the bone, and things are starting to realign, and then it remodels. It could be remodeled in 2 months, 4 months, 6 months, up to a year. Okay. And then it's going to be just like it is, reconstructed, build more over here, less over there. All the same stuff we talked about based on where it is, the forces that are upon it. And typically for young, healthy individuals like you, in a year, you wouldn't even know there was a broken bone. If they had to put hardware in there, sure you would. But eventually that would, maybe a year or two after that, if you took the hardware out. Some hardware is designed to stay in. It's not worth taking it out. And that's and we're skipping that part. I do want to show you a few of these slides just to give you some context. And I just looked up fracture images online. I came up with this site. It's from UK Radiology Masterclass.co. They don't do .coms, but UK. Take a look at this. So, fractures, they're showing this is transverse. The reason transverses are hard, they're less stable, depending on the bone. The humerus particularly, very unstable. If they're at an angle, a lot easier to deal with. Surface area. And this is an oblique fracture. And again, you can see it's through and through. This is a 5th metatarsal, very commonly injured. The bone, it depends on it. Your little toe is a frequently fractured toe. But this area here, what impacts that, there's a tendon that inserts at the base of the 5th metatarsal. And there's a very famous fracture that yanks this piece off. When you yank off a piece of bone, they have a picture of one, it's not great. It's called an avulsion, AVULSION fracture. And that's a very common sports injury. And so here's that spiral fracture. Again, spiral tibia, adult bone, solid bone, not dollars to donuts, a sports injury. And here, this is when you say sagittal plane. The big problem with air, right in the joint. So you're really going to impact. You're going to learn, if you didn't, believe me, the most complicated joint in the human body is the knee. And now that just got a lot more complicated. That's going to be an arthritic knee down the road. 10 years, 20 years, whatever. Sooner or later. Here, fall from a height. Typically. That's typically what you see in a calcaneal fracture like this. What happens when somebody falls from a height? Always, and basically, I had a case very similar to this with a patient of mine for many years, a truck driver. Jumped off the back of his truck, from maybe 4 feet. Pretty agile man, probably mid-40s to 50. Hit a heel just wrong, crushed it. That's not what he had. He had multiple fracture lines. So you always, when you have somebody falling from a height, they hit their heels, they fall forward, their wrists, the top of the triangle, the back. Look at all 3 of those areas, because that's where the force goes. When you learn where the force is, there's a certain predictability to what may or may not go wrong. And so there's a lot of different directions they're talking about. This fellow was so bad, I know it was way out of my pay grade. So I referred him from our area down to the orthopedic foot specialist here in Pittsburgh. He was at UPMC or AGH. Can't seem to grasp it. It was a good 30 years ago. And I mean, he had to do a very complex procedure just to put all these, must have been 10 pieces put back in place. Hold it. I know that down the road, that probably limited his career, his ability to get around. I mean, that was a really bad injury. Because again, this joint here between the talus and the calcaneus probably had to be fused down the road. So they had to do for Tiger Woods, the golfer, okay, because of all the events after his car crash. And now, oh my goodness, that's comminuted, boy. I can't even describe how that could have happened. My suspicion is this was something really bad happened to this person. I'm thinking it could have been assaulted with something. And now here's that fragment. Remember, that's that third fragment. Now that's in pretty good alignment. That's a metacarpal. You know, maybe that's, I don't know, fourth metacarpal down here in the hand. That probably would heal okay, I would think. Here you can see, oh goodness, multiple fragments. They call it segmental. Here and here. With those twisting, remember those bones, interosseous membrane between them. I mean, one part breaks. If you like that spiral fracture in the previous series, if you see that, you always got to X-ray up by the top of the fibula. That thing's twisting and they're together. Almost done. I just want to show you. I didn't get a whole lot of that. This is osteoporosis. Here's normal. You see how bone is. This is something called multiple myeloma. This is a disease. It's kind of a cancer of a certain white blood cell in the bone marrow, very destructive. You don't have to treat it typically with bone marrow replacement. Here's a benign. Remember, it doesn't have to be cancerous to damage the bone. It's there. And then if you want to look through the rest of these, you can see, there you can see osteoporosis. This is a prosthesis, like a hip prosthesis. And then a lot of these will show you this, what gets some of the metal they put in. I know we're almost out of time. Make it look good. There you are. And so this is the kind of stuff that they would use. Thank you very much. See everybody Monday. We'll finish the bone chapter. We'll start joints.